Thank you very much for that introduction. Thank you to the organisers for inviting me to speak. This will be a little bit of a change of pace from the earlier session. These are my disclosures. The objectives of today's session are to talk a little bit about our understanding of the pathophysiology of immune-related adverse events, which is the terminology, as you're aware, that's often used to describe the toxicities related to immune checkpoint inhibitor therapy. We'll talk about incidence, timing, and the nature of the more common immune-related adverse events, and a bit of an overview of their management. Significant limitations and disclaimers before I even start on any of this is that really all of this data comes from the land of oncology, and everyone there has a tumour. Sometimes they have quite a lot of tumour. We don't have much data that's outside clinical trials. Very few patients have underlying liver disease or viral hepatitis, certainly in the data where much of which I'm going to present today. But most of these patients do have advanced oncological disease, and a lot of them have had more than one line of potentially quite toxic chemotherapy. So overall, you're creating quite a different patient population. Not included on this slide, I am a clinical hepatologist. I'm not a virologist. I'm definitely not an immunologist, and I'm not an oncologist. So take from the rest of this talk from what you will. All of that being said, I think this audience is very familiar with the mechanism of action of immune checkpoint inhibitors, but for anyone who may not be so familiar, these are monoclonal antibodies which are targeted generally against CTLA4 or the PD-1 or PD-L1 axis. Generally speaking, they give the immune system that kick we were talking about earlier. They increase effector T cell function and proliferation. They work in slightly different non-redundant ways, but globally, our understanding of their function and the way that they interfere with immune homeostasis to result in these adverse effects is through their effects on effector T cell activation and proliferation, their reduction in T regulatory cell function, and through increased pro-inflammatory cytokine production. And there's quite good animal model, preclinical, and translational evidence to support these mechanisms. They may have effects more widespread on B cells and enhanced humoral autoimmunity. And in the land of cancer, there's potentially a mechanism where there is antigen cross-reactivity. So your effector T cells may recognize antigens that are present in the tumor, but also similar antigens present in host tissue. And there's some evidence to support that. Other models, models that I actually quite like, separate toxicities into toxicities that you see at barrier tissues, so at the respiratory epithelium, the skin, and the GI tract, where potentially you have a population of effector T cells or immune cells that have been exposed to bacterial antigens, but under normal circumstances are suppressed by immune homeostasis, to put it simply. And when you disrupt these mechanisms, you potentially activate these cells. And that's one explanation, that's certainly our hypothesis that's proposed for toxicities that occur at these barrier sites. Toxicities don't just occur there, they can actually affect any organ system. And it's slightly harder sometimes to explain how you get immune side effects in more sterile sites, but it certainly happens. Mechanisms that have been postulated are around perhaps autoreactive T cells that may not have been cleared by the thymus that are then allowed to run rampant. Again, we don't really know, and a better understanding of these toxicities will be important, particularly if you're looking to use these agents outside the cancer setting and in people potentially who are otherwise healthy. The end result is an immune-mediated attack on healthy tissues. It sometimes gets described as being like autoimmune disease. It's not exactly the same, and the good example that I'm most familiar with is autoimmune hepatitis. And checkpoint inhibitor hepatotoxicity is really quite different in terms of its presentation and its response to treatment to checkpoint inhibitor hepatitis, and it's the same in other organ systems too. So this gives you just an overview in the top panel A here of some of the clinically important immune-related adverse events with PD-1 blockade or with anti-CTLA4 containing therapies. As you might expect, as the mechanisms of action are slightly different, the predominant toxicities that you see are slightly different. But I think the take-home message is that toxicity can pretty much affect any organ system, and any clinical syndrome that you care to imagine has probably been described in association with checkpoint inhibitor therapy. These are clinically important because these are the ones that will occur more often or maybe less common, but are potentially much more severe and maybe even fatal in a small number of cases. Panel B down at the bottom there shows you that there's an inverse relationship between frequency and severity. So the toxicities that you see most commonly, skin, joint, gut, fortunately are not so severe, but the toxicities that occur less commonly, nervous system, heart in particular, have the potential to be fatal. There are some postulated risks for individual patients to develop immune-related toxicities. Unfortunately, we cannot clearly predict those for an individual patient at this point in time. It would be very great. It would be great if we could. I'm talking about frequency, just to put some numbers on that, and bearing in mind, of course, this is all from cancer clinical trials. These are some combined data from phase 3 trials of combination therapy, anti-PD-1 and anti-CTLA-4 in purple, anti-CTLA-4 in green, and anti-PD-1 therapies in orange, just showing the reported incidence of various different organ-specific immune-related adverse events. So if we focus maybe more on the PD-1 side, which is the orange bars, about 15% of patients developed the more common side effects, generally colitis in GI, dermatitis. Pneumonitis are affecting the lungs, potentially more severe, perhaps 5% in these trials. Subsequent real-world experience actually suggests that might be a little bit lower, more common in PD-1 than PD-L1. The neurological or cardiac toxicities are not included in this study, but have been reported in perhaps 2% of cancer patients treated with PD-1 or PD-L1 therapies. Checkpoint inhibitor toxicities typically occur relatively early in therapy. Now, of course, bearing in mind these patients are receiving ongoing, sometimes very long-term courses of treatment. They're not just getting one-off infusions. And you tend to see the treatments emerging somewhere between weeks 4 and weeks 12 of therapy. Having said that, it's very important to recognize that there's a huge variation described here, quite different to other types of drug toxicity, and the latency can be as short as a few days in some cases, but there's also been reports of checkpoint inhibitor toxicities after patients had been on treatment, stably maintained on treatment for many, many months, and even in 1 or 2 cases after patients had completed therapy and been off therapy for up to a year. So any patient who's been exposed to checkpoint inhibitor therapy, you kind of have to maintain an index of suspicion for immunotoxicity. Just going to spend a few minutes working my way around this little flow diagram, which just to focus on a few key points in the management of these toxicities, particularly for patients who are treated with checkpoint inhibitor therapy. It would be great if we could prevent it from happening. That is tricky because we don't know exactly why it happens and we can't predict who it may happen for. We do recognize, certainly in the world of oncology, that there's an increased risk with combination checkpoint inhibitor therapies, and there's an increased risk in patients with pre-existing autoimmune disease. They definitely have more risk of flare of their underlying autoimmune disease, but they also have a higher risk of developing de novo immune-related toxicities. Any patient who's starting checkpoint inhibitor therapy needs a really thorough baseline assessment, and they also need very close on-treatment monitoring, physical exam, and a whole panel of blood work, and that's usually timed to coincide with their infusions. Again, bearing in mind that these toxicities can develop after a significant latency, that follow-up needs to continue even after the patient completes treatment, and how long that's for is an open question. If patients do develop symptoms, it's a good idea to have a low threshold to investigate those. Some of those more significant toxicities, the cardiac toxicities, the neurological toxicities, have the potential to progress very rapidly. And I'll touch on fatalities in just towards the end of the talk, but in patients who did die of myocarditis, for example, the time from onset of symptoms to death was 30 days. So any new symptoms really do need to be assessed. Toxicity is a diagnosis of exclusion. There's no diagnostic test that will confirm that your patient does have checkpoint inhibitor-associated toxicity. So outside the oncology world, we don't have a great feel for how common these toxicities are likely to be. And it might well be that your patient has got food poisoning and does not have checkpoint inhibitor-associated colitis, and you don't want to be stopping therapy and giving them high-dose steroids. Campylobacter, for example. So you, if in doubt, involve a specialist early. That's, I think, the message that we've kind of sent to oncology from hepatology. We like to know about these patients who develop checkpoint inhibitor hepatotoxicity. The knee-jerk response has often been to say, well, they've had a checkpoint inhibitor, it must be hepatotoxicity. We'll stop the checkpoint, we'll start steroids. And we've published data to show that actually in the liver, patients treated for various primary malignancies with checkpoint inhibitors, about 85% of them actually have a different cause for hepatitis. It's not checkpoint inhibitor-associated hepatotoxicity. So think of other causes, check for other causes, speak to a specialist. If the patient does have checkpoint inhibitor hepatotoxicity or all other reasonable causes have been excluded, the severity of the toxicity is assessed using the common the terminology criteria for adverse events, which are derived from oncology clinical trials. And this really reflects the fact that all the management guidance is derived from oncology clinical trials, some anecdotal experience, and some retrospective series. There's some very detailed management algorithms that are laid out in the Oncology Societal Practice Guidelines. They're very, very helpful, especially if you're dealing with things that you don't normally deal with. And they're effective, but they have never been prospectively evaluated for any of these toxicities. These are a couple of good examples from the European Society of Medical Oncology and the American Society of Clinical Oncology, to name but two. These are probably the most common two that are referenced. A broad overview splits the toxicities from 1 to 4. There is actually a fifth toxicity, which is death, but for practical management, that's probably not so relevant, unfortunately rare. Grade 1 toxicities can normally just be monitored while you consider investigation for other causes. Grade 2 toxicities generally involve holding checkpoint inhibitor, and depending on exactly what organ system is affected, you may wish to investigate, you may even wish to start treatment if you're worried, if it's neurological, if it's pulmonary, if it's cardiac, you're going to have a lower threshold for worry with those toxicities. Grade 3 and 4 is when people are getting sick. Usually involves organ dysfunction, usually involves stopping the checkpoint inhibitor, possibly indefinitely. Again, in the land of oncology, patients may not have other good treatment options. They might get re-challenged, but even then, there's a concern. These patients will almost always be treated and may require admission because, as I've mentioned, some of these toxicities can progress rapidly. Just a few exceptions. Dermatological toxicities, you can often manage those quite simply in topical therapies. Endocrine toxicities may be permanent, actually, and usually require replacement therapy, but not immunosuppression. But for most other toxicities, eye-wateringly high doses, sometimes of corticosteroids, are the mainstay of management for most patients who need treatment and don't resolve simply with withdrawal of the checkpoint inhibitor. It's important then to monitor the patients for the complications of the treatment. You've monitored them for the complications of the checkpoint inhibitor. Now you've potentially put them on 2 milligrams per kilograms of prednisone. There is a significant risk of infection, hyperglycemia, well reported in the literature, so it's important not to stop monitoring them at this point. Some patients do not respond to the steroids. Fortunately, the majority do, but there are a whole array of second-line immunosuppressive therapies that have been developed and tried and tested depending on the specific organ toxicity. Anti-TNFs work pretty well in colitis. We tend to use mycophenolate mofetil for immune-related hepatitis, for example. It's a good time to check the diagnosis. If you haven't involved a specialist up to this point, it's a good time to do that too. Generally speaking, once the toxicity has resolved and you've been able to taper off the steroids if you had to use them in the first place, that specific toxicity does not tend to recur unless you re-challenge the patient with a checkpoint inhibitor targeting the same pathway. But remember, different toxicities have different latencies. In hepatitis, for example, we do actually see emergent checkpoint inhibitor hepatitis as patients have their steroids tapered for some other kind of toxicity. So different toxicities can emerge. Unfortunately, it's not one and done. Most of these toxicities resolve over about 4 to 8 weeks, and that's whether or not patients have required immunosuppression. Remember, some patients, unfortunately, do develop permanent consequences. Endocrine toxicities often involve a permanent loss of function, joint symptoms may be chronic, and patients with pulmonary disease may develop a chronic pneumonitis. In this series of about 4,000 patients treated at specialist centres, there was about a 0.6% fatality rate associated with toxicity, and the majority of those were due to heart, nervous system, or lung toxicity. So those are really the ones to watch out for. So in summary, checkpoint inhibitor toxicities are seen fairly commonly, certainly in the context of checkpoint inhibitors used as an anti-cancer therapy. In other settings, the frequency remains unclear. Generally, frequency is inversely proportional to severity. Close monitoring is required to detect these toxicities early, as some can cause permanent morbidity and very rarely mortality. Thank you.